in terms of people on the call, we don't have time to go through everyone to introduce themselves, but I'm just going to read the organizations whose leaderships are represented here today. We have Blue Cross Blue Shield of Minnesota, Collective Action Lab, Greater Minnesota Housing Fund, Green and Healthy Homes Initiative. We have Health Partners, Hennepin County Health and Human Services, Minnesota Department of Health, Health Equity Group, Minnesota Council of Health Plans, Minnesota Hospital Association, Minnesota Department of Health, Minnesota Housing, Optum, Prime West Health, Robert Wood Johnson Foundation, Stratus Health, Texas Department of State Health Services, hello Texas, United Health Group, United Healthcare Community and State, Wilder Foundation, and we have our University of Minnesota research team here. So with that, I know a lot of you have seen me present this presentation, but I just want to give a quick overview of, let's see, of our project. Susanna, can you do thumbs up if you see my slides properly? Awesome, thank you. I just see thumbs up. But yeah, so I'll go through very quickly about the idea we have, and then we will move to Eric and then to Green and Healthy Homes Initiative. So again, let's see. So this is a really cool research team representing, multiple schools at the University of Minnesota, partnership with Minnesota Hospital Association, and really interesting groups here that some of whom you have leadership here today, supporting our project exactly in this way, listening to us, giving us feedback. So social drivers of health, extremely important for shaping the health and well-being of individuals, impactful on racial and health equity, and we know that they drive a large fraction of healthcare costs and adverse health outcomes. And community-based organizations are very well positioned to address some of these needs, but they're underfunded and they lack sustainable funding. As a result, what we hear is that it's been very difficult to scale some of the SDH interventions and difficult to offer continuity of care, social care. Again, we talk a lot about the continuity of healthcare, but continuity of social care is really important, and we are not able to necessarily do that successfully. So ultimately, the problem we're trying to address with this project is to address the lack of efficient and sustainable funding of community and social community-based organization, social services organization programs to impact health and health equity. We focus on the Medicaid population in when we think about this financial instrument, which we're calling the SDH bond, Social Drivers of Health bond. Again, the idea with this bond is to pool resources across competing health plans to create a stable long-term financing for interventions. We have linked our health affairs paper to this group. So again, please go back to the paper for full detail. It should be free access to everyone. And so we hope you will read and send us individual feedback too. But the idea is that it's allowing multiple health plans participating in the Medicaid program. And we're thinking Minnesota, but idea is really applicable to other states as well. And also allowing for some public-private partnership. And funds will be raised with this bond, and they will then be used to finance community-based interventions to target social issues such as food insecurity, housing instability, transportation, structural racism, among many other SDH factors. And the idea is that the interventions will result in healthcare cost savings, which will then be used to pay the investors back. Again, we're specifically thinking about Medicaid for this particular project, where 84 million individuals in the US accounts for 17% of the healthcare spending. And we know this is a population where we have complex and extreme SDH complications. And there's also an important business case, because from the perspective of a Medicaid managed care organization that receives capitated payments per enrollee, and that they're at risk for medical spending, addressing these SDH needs of the enrollees will result in cost savings For example, results in reduced diabetes complications, healthcare utilization, and we know that there is evidence that shows from the literature that we've been reading, as well as the key informant interviews, that such initiatives are cost-effective and they return a positive return on investment. And also, Medicaid programs have actionable policy levers and some flexibility to address the SDH needs of their communities. We know that there are based on 2019 data, for example, there are 40 states that are working to address social needs with a bunch of different activities through demonstration waivers as well as managed care contracts. For example, of the 41 states with Medicaid managed care organizations, 32 of them had an MCO contract requirement to have at least one SDH strategy. 28 of them required referring enrollees to social services and so on. So Medicaid may be a really interesting place where some actionable levers can be employed. Now, let me move on to our framing around this question as a wrong bucket problem that we are trying to solve. Again, from the perspective of the MCO, addressing these needs, addressing food insecurity, for example, of a diabetic enrollee, will improve access to healthy foods and nutrition, and this will reduce in the diabetes complications. But we know that it often takes a very long time for SDH interventions to actually return the benefits, right? They get realized in the long run in terms of these avoidable cost savings, avoided ED visits, avoided readmissions or unplanned admissions. And there are two reasons, though, why for some of the future return may not be realized by the MCOs, and that creates what we're calling the wrong bucket problem. One, we know that Medicaid is characterized by really volatile enrollment patterns and coverage, which we know the Medicaid churn rate with monthly changes in eligibility and disruption of coverage. And also, a lot of the times these states have a competitive bidding process for their Medicaid contracts. And a given Medicaid MCO that is serving, say, a county and a population in a given year may not be present in the same county, may not win the bid in that county down the road, and thus they don't realize the full benefits of the SDH investments. So ultimately, we end up with inefficiently low levels of SDH investments because of the fact that the MCOs are not able to fully realize the future benefits of their investments. So this is our plan. What we are saying is let's create an SDH bond, which will be issued jointly by multiple MCOs under a legal entity called a special purpose vehicle, SPV. And here you have two MCOs, MCO A and B, that served Medicaid population, let's say in a geographic area. And so they would be issuing this SDH bond, the SPV jointly, and an individual investors like all of us or mutual funds will be buying the bond, expecting a bond return. What makes this a social bond is that the SPV ensures that the proceeds, the funds raised, will actually go to SDH interventions of the MCO enrollees. And overall, health will improve, cost savings will be realized, and when it is time to pay back, MCOs will pay back the investors with these realized cost savings or a portion of them. But the interesting thing is we can set up this bond so that MCOs pay back based on the estimated cost savings, which could be tracked based on their patient enrollment in MCOs or patient participation in SDH interventions. So basically what this structure would say is that if MCO A loses a lot of their patient population to MCO B down the road in this geographic area, MCO B will be paying more of the outstanding bond proceeds. And this solves that wrong bucket problem we're talking about. Lots of additional benefits of it, harnessing the broader power of capital markets, bringing a large influx of funds, not necessarily asking any MCO to upfront any of the major costs or to fund these initiatives. We're creating really a one bucket problem from the wrong bucket problem to allow continuity of social care, even if enrollees switch plans. So in our vision in the picture I showed before, the funds will be raised for both MCO populations. And so if people switch from A and B, they still have access to their social care. reduces the incentives of the MCOs to cherry pick and release because we're thinking of the bond repayment to be based on estimated savings instead of tracking actual interventions or medical costs. And then it's a flexible structure. Nothing prevents a state Medicaid agency or any other public agency for that matter to be part of the SPV, to be an insurer of the SPV, and a partner with the MCOs. Lots of questions are, outstanding. This is something our team is working on. How do you structure the bond, in terms of maturity? Is it backed by federal state entities? How many MCOs, etc.? And understanding the different types of STH investments to structure of the bond. And this conversation today is really valuable today. We're going to hear about housing because housing interventions, for example, are more capital intensive projects. Yielding benefit over a long run, transportation same, but then we also have other types of annual outlay type projects, for example, access to tailored meals. And so it will be interesting to kind of blend in these two very different types of interventions to be funded by a fund like that. But in all cases, all of the terms have to be agreed upon upfront, and also coordination with state Medicaid agencies. I'm really glad we have folks from MDH here as well as Texas. Again, whatever we create will need to exist within the existing legacy structure of Medicaid financing. Questions and conversations around how a bond like that can be incorporated into the regular MCO procurement cycle. For example, would states look favorably on managed care organizations that participate in an SDH bond? Would policymakers allow for higher contract amounts to reflect organizations' commitment to SDH activities? Yeah, so lots of things. Monitoring the use of funds and measuring returns. SDH interventions, at least for now, they don't have procedure codes, so not easy to track as other healthcare utilization. Maintaining data and tracking is going to be really important. Identifying appropriate data on return on investment, of course, is a big thing. We've been doing a lot of work on key informant interviews and literature surveys, and we do have a good evidence and growing evidence, so that's encouraging, but there's still a large gap. And so, we are creating some sort of take-home messages around how these programs should be tracked and what kind of data should be reported to even further improve understanding of the benefits of the SDH programs. And again, how do we select interventions? Let's assume we raise the funds, and then is it going to be through an RFP process? Will the individual investors be engaged in the process? We know that in the nonprofit healthcare, their community health needs assessments, they could be leveraged perhaps. So there's some ideas there. So our approach has been sort of kind of refining these ideas, refining several solutions. We've been looking at ROI of the SDH interventions, and now we're conducting some simulation exercises. I'm going to share two more slides. The message is, we looked at food and housing in the literature in depth, and the good news is on the ROI varies depending on what type of population, what type of food programs, what type of outcomes are looked at. But we've been doing a good job sort of translating everything we find in the literature to an apples-to-apples comparison in terms of an ROI measure. Overall, we find that across all food interventions, we have an ROI of 126%. And of course, there is a distribution around it. In terms of housing interventions, same idea, different types of housing interventions. Some are heavy users, some are low income, high cost individuals, some are dual eligibles. But on average, we have an ROI of about 75% when we look at all housing interventions. And again, we have a distribution. So next steps, we're going to keep continue ROI mapping, and that will be sort of the next paper that will come out of our project. Continuing to build some of the Monte Carlo simulations on figuring out how a bond and the type of mix of projects, how would that perform, and continue engagement with all of you in terms of understanding bond futures, in terms of all of the challenges that I mentioned. Again, to summarize, this is not an implementation project as of now. However, we are very encouraged with the idea and the reception on the idea too. We would love to be able to look for opportunities to start thinking about implementation and the next steps. So I will stop right there, and maybe we will move to Eric very quickly. So Eric could tell us a little bit about their work in Minnesota. Thank you, Eric. Do you want to share your slides?
Yeah. Do I have the?
Yeah, you should be able to share.
Host disabled participant screen sharing. So if the host could allow me to share, I'll share.
Becky, are you able to? Let me see. You should be able to.
Oh, I think I can now.
Yeah, great, thanks.
Yeah, I think they switched it. Let's see. Can everyone see this?
Not yet.
Yeah, I'm still getting a reading of not able to share. Let's see. Here we go. Let me see if I can do it. How's that?
There we go.
Excellent. Okay. So thanks. It's great to be here. My name is Eric Muschler, Director of Housing and Health Equity at the Greater Minnesota Housing Fund. And the Greater Minnesota Housing Fund is a affordable housing intermediary community development financial institution with over 25 years of experience serving all of Minnesota, over 200 counties. We've supported the creation of 20,000 homes with over $1 billion directly invested, leveraging about 3.4 billion. We work in the full continuum of affordable housing, so from temporary shelter to affordable home ownership, with the bulk of our work being in the rental housing category. We also advance system improvements in affordable housing through identifying opportunities, exploring new models, innovations, and filling gaps in the continuum where populations underserved by the marketplace. 30% of the people served are people of color. A full 20% of the units developed are permanent supportive housing or service-enriched housing. So we're connecting housing and health, and it's been a significant part of our work. We believe that housing is health and that it is the most critical social determinant of health. Programs like our Emerging Developers of Color program, our capacity building efforts, and the Housing and Health Equity Initiative, which is what I'm focused on today, were created to inform and spark changes in the housing system to be more efficient, effective at addressing inequities and building healthier communities. We do this work in partnership with people, with communities, government, developers, and investors. As a CDFI, we have the Minnesota Equity Fund, the NOAA Impact Fund, the Community Development Revolving Loan Fund, and grant making and technical assistance to advance our housing and community development work. We use this robust platform of equity, debt, tax credits, and grants to advance a strong pipeline of development projects that help us implement strategic programs and advance systems change and improvements. We work regularly with social impact investors, including healthcare, to achieve their and our overlapping interests and goals, making sure everyone's stably housed and has a safe place to call home. As an intermediary, we have built and managed targeted funds like the NOAA Impact Fund and regularly manage social investment capital to place it wisely and allow for capital to advance housing while returning earnings and principal back to our investors. Today, I'm talking about the Housing and Health Equity Initiative, which is an initiative within the Greater Minnesota Housing Fund. And that focus of that is advancing the investment and development of affordable housing as the most impactful social determinant of health. The goals include convening healthcare leaders in a learning cohort, a community of practice and building cross-sector networks, building a pipeline of projects, which we build off of our existing pipeline and grow, catalyzing upstream investments in social determinants of health and housing, so increasing the investments from particularly healthcare toward housing, and shifting in policy and practice that as we learn from what we do. This year, we kicked off the Minnesota Healthcare Fellows cohort. It's the first Minnesota learning cohort. We have 6 of the top 10 healthcare systems that are in Minnesota learn in this cohort. 30 fellows, 6 teams from these 6 different institutions. We have a partnership with the Center for Community Investment in Minnesota Housing, who are co-sponsors of the effort. We share knowledge and connect people through cross-sector convenings quarterly, and we have a quarterly newsletter where we share stories of success. The pipeline of projects we build from a strong general pipeline that we already have, less so the housing and health equity. That's the area that we're growing. But in tracking all of our developments last year, we found that 80% of the workforce units were within 2 miles of a healthcare facility or employment center. Last year, 200 were permanent supportive housing units or service enriched units. We've also, in nurturing new projects, are constantly looking and providing letters of support to things like the American Indian Community Clinic, a federally qualified health clinic that's working on building a new facility with affordable housing above it. There's two other projects that we're connected to that we're trying to encourage that are similar to that. Around catalyzing investments, we're currently building a $100 million housing impact fund with a few significant healthcare investors already committed. And that fund is really focused on workforce housing and focused on naturally occurring affordable housing, so preservation in communities, and then housing and health projects that are connecting and linking more directly the housing and services with the health services with housing that we can advance. So all of the learning cohort members, the purpose statements are focused on the investment roles for healthcare and housing, and we're exploring models with them like land donation opportunities or the use of a low, no subsidy workforce housing, or those sort of mixed use projects that I talked about with the American Indian Community Clinic. In policy, we're just building relationships from healthcare policy to housing policy, and trying to bring the healthcare voice more strongly out into the affordable housing world. The Medicaid waiver reform, for example, is an important step forward for the system. So housing stabilization services are very important and they're doing some good work, but we think there's some serious regulatory change that needs to occur for this to be most impactful. We also have some evaluation work going on. So we're working with Success Measures, a national research and consulting arm of NeighborWorks America, to develop a consistent mechanism to survey resident outcomes related to health and well-being and capture more the impact of affordable housing and supportive housing on the people that live in it. Too often we focus on just the units, the investment, the leverage, without taking the time to understand and articulate the difference that housing stability makes in the lives and well-being of individuals and families in their home. The first surveys are going to start this year, and we'll have annual surveys to be able to track forward on these health and well-being measures. And there's a growing number of examples of housing and health equity developments. Many are related to permanent supportive housing, but there's also recovery housing for chemical dependent or mental. The Avivo project is an example of that. Ex-offender housing, Solus apartments in Mankato. More mixed-use development, like the Wellness Center and open spaces at the Commons at Penn, or childcare built into an affordable housing project like Cascade Creek, or working with homeless youth of enriched service supports like the 66 West apartments in Edina. So here's the fellows that are, the team of fellows that are coming into our into the Minnesota Learning Cohort. We're already through this cohort building deeper understanding and relationships across the healthcare and housing fields. The purpose statement for each one of these institutions for why they applied to send these teams were all focused on roles that they could play in housing as a critical social determinant of health. As I said, 6 of the top 10 health systems are part of the effort. We have one payer. So we have Blue Cross Blue Shield, which provides statewide insurance plan. Then we have 5 health systems. 2 of them, Centricare and Essentia, are serving different regions in greater Minnesota, and the other three, mHealth, Fairview, Children's, and Alina, serve mostly metro area, but they do have facilities in other places. At least 2 and maybe 3 of these are clear sort of place-based strategies by these systems. So they're looking at their role as an anchor institution and expanding it. And we find that there's a lot of interest and curiosity and potential for collective action across these systems. So it's a wonderful engagement and opportunity to shift more healthcare institutions from discussing housing challenges to getting more directly engaged in the work. But there are still challenges. It's challenging to get healthcare associations to join the effort as a co-sponsor, which we tried to do, but there's many priorities ahead of this work. So who will sustain and nurture this line of impact investment work from the healthcare side? There are always distractions in healthcare, you know, COVID issues that rise up again, or the workforce shortage, you know, losses at hospitals currently is a real issue. So even mergers, Fairview and Sanford merger is a big issue right now. So there's always these distractions that occur, and it's challenging to keep folks focused on what that real connection is and investment in affordable housing. At the same time, the housing field remains hesitant to pursue housing stabilization services, for example, because Medicaid billing requirements and differences in how supports are provided. So can healthcare and housing work together on policy and regulatory issues that would allow this to be a much more transformative opportunity? Health equity and racial equity are often used interchangeably, but I'm not sure what this means within health systems at times, and I'm not sure what it looks like in practice quite yet. There's also, we're just very interested in demonstrations and actions and in replication. So looking to demonstrate new partnership models, investment practice, and innovative developments that increasingly support the residents, not just the units and communities, in achieving healthier people and places. So in summary, Greater Minnesota Housing Fund is deeply engaged in this housing and health equity space. Our focus is engaging on the investment side of the housing and health equation, and already have active investor relationships with healthcare institutions. And we have activities in place on the ground and systems in place to expand partnership with direct healthcare involvement as it relates to housing and social determinants of health. So with that, I'll turn it over, I guess, to the next speaker. We're not going to take questions quite yet, but I'm looking forward to the discussion.
Thanks so much, Eric. Thank you. Ruth, Michael, who's sharing on your side?
So Wynn is going to share the slides. I'm going to be your host.
Great, thank you.
For the good work of that. Just to say, Wynn, if you want to go to the next slide, right? So we're today going to talk about one project to kind of illustrate how we did that, building on the social impact bond and the social bond piece. But let me just say that listening, Pinar, to you and to Eric, all of the good and right thinking. It's been a long time since I heard people referring to the Monte Carlo calculation, so I feel at home. I'm grateful to be back in the mix on that. And also, I'm happy to hear that we have people in Texas on the phone line with us, because we've been looking at this outcomes-based work and this social drivers fund type of work in Texas as well. But to get to know GHHI just a minute, we are just celebrating our 30 years of work in the field of advancing healthy housing in order to pursue our path around environmental justice and racial equity, for which we were founded. So our work is really looking at those drivers in implementation work on the ground in numerous communities around the country, in the measurement of many things around health, economic, and non-energy benefits, and as well, Eric, about how we measure racial equity. I saw on your slide. Love to talk to you about that. And Baltimore is our flagship, but we have staff around the country, and we've worked with over 45 states and over 75 cities thinking about how do we advance this work of investment in the social drivers of health through healthier housing. So let me take you through a little bit of what we did in New York. That will be, I think, illustrative to what you're thinking about, and what I think that you are thinking about that is so important. We did 15 feasibility studies looking at pay for success and social impact bonds. In many states, the trip up point was the lack of spreading the risk. So I think the fact that you're looking at that risk spread in your bond is so critically important. But in New York, we formed what is called the New York Healthy Homes Collaborative, and working with Affinity by Molina, we raised $4.75 million in capital from GHHI as the junior investor through support from a national foundation, and Northern Trust through their community reinvestment fund. And we set out to show that the work we do in asthma reduction, improving indoor air quality, and improving the general health of housing through both the education, home visiting side, but also the housing intervention side, would improve outcomes and quality of life for 850 or more families, mainly in the Bronx, but throughout New York's 5 boroughs and 10 counties, and established a precedent for how do we look at this as a loan using a special purpose vehicle, really to address those social determinants and be able to both return on investment, because you will see, not to bury or advance the lead, but we're paying back this work solely through Medicaid savings. Only transaction in the country is paying back solely through the savings created through Medicaid. But we hope to reduce the acute care utilization, ER visits, hospitalizations, and improve quality scores, right? And we did this coming out of COVID as a COVID recovery measure. But what we know from many of the studies we've done, both the feasibility studies with Robert Wood Johnson and Episcopal Health Foundation and the federal government, but also the studies we've done for the U.S. Department of Housing and Urban Development, we know that what we will really get is housing stability. We'll get lower ER and emergency room visits significantly. And we know that we'll have a better opportunity for kids to go to the classroom, healthy and ready to learn, improve attendance because of asthma's impact on absenteeism. And we know through our studies that we improve work attendance. So we get to core quality of life, social determinant of health, and social drivers of health measures. And I'll talk a little bit more about those studies in a second, but go ahead to the next slide. So we pulled together a mainly local partnership, but could not have done it without the support of New York State Health Department and Medicaid, who made the provision available for us to use value-based purchase pathways to build this transaction. Affinity by Molina is the healthcare provider who's making the referrals of patients who have hit the emergency room over to our project team, AIR NYC, and the Association for Affordable Energy, doing the home visiting, the case management work, and the housing intervention work. We're serving as the project design and now the project manager and the junior investor, keeping 2 sets of work there. And Northern Trust is the senior investor. We have put our capital in first. They're about to put their capital in now that our referrals are hitting above where we want them to be, and then we use the New York City Health Department as a technical advisor on some of the pest management work and the other measures around asthma. And then we are using primary care development, or PCDC, which RWJF helped to lift up as a financial intermediary in this, our lockbox, for the better way to say it. So I want to go to the next slide. So here's how we kind of brought this about, right? We did an initial feasibility study and working with actuarial analysis, GHHI and Milliman spent a number of years together kind of perfecting the work on how we use patient data to do projections on savings and on other measures. We developed the skill and are able to do it on our own at this point as a high trust nonprofit, audit agency nonprofit. But we built out there the economic projections, how to onboard the service providers. We found those. We did the operational planning with all of the partners at the table, and did the analysis for the system on payment mechanism analysis. The next 3 years, a little bit interrupted by COVID. When we were at the starting line, we had to pull back for a few years, but we were able to raise the upfront capital. There was no doubt that everybody thought this was a good thing to do, but getting people to go, a couple of years back versus today was a much different story. We then did 2 small-scale pilots just to work out the kinks of how it all would work from soup to nuts, if you will. And through that, we then wrote a final operational plan and developed the VBP contract and did all of the work to execute that. Starting in February 22, understanding that in the midst of this, not only did we have COVID, we had the healthcare providers sold. So we had to reorient everyone in the process. Most things will not be as long entailed as others. This one, we got everything thrown at us, changes in leadership at Medicaid in New York, the healthcare entity being sold, COVID happening. But we got off and launched, and we are now implementing those services and starting the yearly evaluations with success payments coming soon, and the next tranche of capital coming. We'll go to the next slide, and I think we'll talk about the terms in just a minute, so you understand that. But we're looking at this, a number of our, obviously, types of work that we do in healthcare. We have about 5 or 6 different lines of healthcare funding. Many of them reach in different and broader populations. This is looking at the Molina population, and they're identifying them through an automated process and sending that batch of referrals to AIR NYC, who's serving as the anchor partner. They are doing the intake and introduction to the program. It's a warm handoff from Affinity, who's also socialized that with us. And then starting into the work with AIR NYC to do the investigation of the unit, the status, and what, if any, housing interventions need to be made, following very good standards on the asthma home visiting and self-management tools. And they're overseeing the first phase of this beyond the social needs screening and behavioral health. They were overseeing the integrated pest management, and then they're moving it to AEA if it's ventilation, carpet removal, or other window replacement or other matters. And then through that environmental intervention, we're looking at, as I said, pest management. We do a comprehensive, AEA does a comprehensive look at the home environment, and then use the measures that are set out that are evidence-based on the asthma reduction. And then AEA also follows up with QA/QC, and then we've got 3 follow-ups every 3 months with AIR NYC. And if needed, if we see either in the infrastructure work of the house or in the home visiting, if we need additional home visits, we will do that based on social need and the risk factors. And the AIR NYC is assessing those on an ongoing basis. So here's how the actual transaction is working, right? The funders, Northern Trust and GHHI, right, funded PCDC in this instance, right, who then is advancing money to NYC and AEA based on the referrals and the need to make sure that they're capitalized to be able to do the work. We're paid a management fee quarterly to look at the overall evidence-based practices being used, issues of referrals, or any of the management of the actual intervention cycle. PCDC is getting paid for their fiscal management and ensuring that all the reports are in and that they get Molina to agree and sign off on payments based on cost savings and based on the cases hitting the measurements that we laid out in projections. And those savings, right, that inure to affinity are then sent back in the terms of success payments back to PCDC, and then out first to Northern Trust and eventually to GHHI. So if you want to go there, so then through the Healthy Homes Collaborative, we have an intercreditor agreement with Northern Trust and GHHI, and we serve on a governance committee overseeing that with Affinity. We have 2 loan agreements, both with PCDC. We are doing the project management. NYC is the main service provider, AEA, the intervention provider on the housing part of that. And then Affinity is the back end payer. It's all tied to that success agreement that we meet certain benchmarks of lowering emergency room visits and hospitalizations. Michael, I don't know if you want to add anything to that success agreement, or if we're going to get to that in the slides.
I don't have anything to add. Thanks.
Okay, that's great. Let's go to the next slide. So we look at, and we are operating in a number of different realms based on the feasibility studies that we did of looking at the various ways in which we can advance healthcare work, whether it's using the in lieu of statute or path through Medicaid, which California is now doing, where docs can write scripts for asthma patients to get housing intervention, whether it's statewide plan amendments like in California or Indiana or Missouri. Many states now are doing that. We've got a number of states that are using unused administrative dollars through pulling down from CHIP unused administrative dollars into SPA agreements, a number of demonstration waivers. And we are in our own program in Baltimore, funded through managed care contracts with AmeriGroup, funding that work directly. And then I know Michael and Wen, if you want to talk about any of these others, but this is the realm of ways to build the capital stack for housing through healthcare. And then most of the programs that we are involved in are also aligning other dollars, whether they're coming from HUD or growing a base of dollars from EPA and DOE on issues of energy efficiency or decarbonization, electrification, as well as some dollars coming from state and local housing and health organizations, ARPA dollars, congressional set-asides, and of course, philanthropy. So happy to answer questions. That's a very quick primer. We were told to be within 10 minutes. Hope I stayed within 10 there. But as I said, we've been able to implement funding out of hospital dollars, taking out of their reserves and investments in communities at significant scale. Center for American Progress just wrote an article on those anchor institution investments. We've got direct Medicaid dollars going in through administrative dollars, and then this mechanism looking at savings. One thing you may want to pay attention to is the US Treasury is soon to come out with a SIPR competition, which would add into the mix repayment from federal Medicaid potentially, and the federal savings as well. So I would turn to Michael and Wen just to say if they wanted to add anything as we close out our speed date here.
I don't have anything yet. I'm sure there's lots of questions.
No, wonderful. Yeah, so we can actually stop recording, Becky. You know, we're at the our project is at very early stages, but it's just so wonderful to hear